Okay, so those of you who are just here to hear about type 2 diabetes, note that this is not a type 2 specific talk, and I apologize about that, but I assure you it will be worthwhile. Like Dr. Bianco said, I'm from the University of Wisconsin. I'm a pediatric endocrinologist there, and I'm presenting on a project that we took on this last year to improve our clinical efficiency. So any of you who work in a clinical setting, hopefully you could take something from this that applies to your own practice. And I have to point out here, I have a couple of co-authors and sponsors here on the slide with me. So Rachel and Whitney are two of our coordinators through the collaborative. This work would not have been possible without them. And Courtney listed here is our clinic manager. And so this is just a shout out to those of you like getting started in quality improvement and trying to make changes in clinic. Engage your stakeholders. So Courtney is our clinic nurse manager, and she oversees the nurses in our clinic, but really has a greater role in affecting change. And she was really influential in getting this work accomplished. So shout out to them. So this work started years ago. I mean, even as a fellow, years before this, I recognized that diabetes clinic appointments take a very long time. Some of that is really important, right? Like diabetes is a complex disease, and we have to like acknowledge that. And for type 1 and type 2 diabetes, there are a lot of components of our clinic visits. That includes having learners, because we are an academic medical center, so we have students and residents and fellows, and it's very important to be teaching the next generations about diabetes care. So that's obviously a critical part. We also have multidisciplinary care, and we're resourced enough that we have dietitians in clinic and we have nurses in clinic. But what we found was like over the years, this sort of expanded to adding more to our diabetes clinic visits. And I think that probably resonates with folks that like when we're making interventions, we're often talking about adding things. And so this is really a quality improvement project around really streamlining and quite frankly, eliminating things, but primarily waste. So that was our goal. That's kind of the overarching goal here. So back in 2022, we kind of looked at some of our baseline data, and I was hearing from other docs who were nervous that I was going to start this work. Like, well, what about learners and what about when we have nutrition? And so I just stratified the data, just a simple bar chart here, just to show like, okay, if we look at our average visits, you can see that MD visits were a little longer than NPs. If there's a learner, it takes longer. If the patient is seeing nutrition, it takes longer. But you can see the average is about 74 minutes. And that was true for type 1 and type 2 diabetes. And those on my team said, it's always been this way. It'll always be this way, which for me in quality improvement means it's time to change. So at that time, back in 2022, and with the help of Rachel Fensky, we implemented a questionnaire. It's on paper. It still is on paper because we don't have resources at UW to turn non-validated tools into Epic patient-reported questionnaires. So we have to still do this on paper and then manually enter it. But I'll show you later how we kind of moved that work from being a synchronous process to sort of an asynchronous process. But we implemented that and achieved a new baseline of 63 minutes. So by kind of eliminating the step of asking patients these questions and entering, and what's on this form, this was a different project we presented years ago, but what was on this form was kind of a lot of the patient-reported outcomes that we're reporting for U.S. News and World Report, but also just for clinical care and for the collaborative. Okay, so in addition to knowing clinic visits were still long, I became the medical director of our clinic about a year ago and started looking more at our Press Ganey patient experience data. And there were a lot of comments about how our visits are too long. Perhaps if you look at your own patient experience comments, you might see something similar. Maybe not, but you can just read through some of these comments. My appointments always take a solid 90 minutes. And this was really key. I feel like I have to repeat the info to 3 different people. Very long wait times, meaning this comment was about wait times once they arrive in the clinic, not wait for the appointment to be scheduled. Sitting in the exam room while waiting for 30 minutes is uncomfortable. 2 hours for a visit is a long time. So you can just see these comments that, really added up. Ooh, excuse me. So this is our key driver diagram. I will call out a few things here, but specifically, I'm going to go through the PDSA cycles next of like, what did we do to tackle this problem? But you can see how our PDSA, we sort of mapped our PDSA cycles here to our key drivers. In part, I did this just to guide my clinical team and sort of provide some explanation to kind of support that change management. I'll get to the specifics of that in a second, but you can see we felt like our key drivers were really around diabetes data. So that ended up being one of the most critical things we did was really focus on the CGM and pump and glucometer data and getting all of that efficiently entered into HealthLink, which is our EHR. We use Epic in Madison, but call it HealthLink because it sounds fancy. We also felt like really optimizing that face-to-face time was really the piece that our patients were commenting on. Like there was a lot of downtime between people in the room. So again, that was another way to sort of like get buy-in from our clinical team that we weren't really, none of these interventions were around reducing the amount of time that any care team member spent with the patient, more reducing the time between those care team members going in. Yeah, and then eliminating repetition, again, that came straight from the patient comments. And then we wanted to be continuously incorporating patient feedback. So I'll hopefully get to how we did that in the next couple of slides. So really the format of these next couple of slides, and I hope that QR code is big enough to scan from where you're sitting. If not, I'm happy to share it or you can look it up. But I really find these change concepts from the improvement guide by Langley and others to be a really useful tool when you're looking at a complex problem and trying to brainstorm like, how do we tackle this problem? Ori presented earlier today, like often we have good ideas of how to fix problems. But I think using a standardized tool to look at, okay, how could I approach this problem differently is good for our clinical teams, our improvement teams to really think outside the box and come up with solutions that maybe we wouldn't have otherwise. So the way these are organized, the change concept on top is literally taken right from that worksheet of change concepts within the improvement guide. So the first two PDSA cycles were really around improving our workflow. Specifically, now so much of our diabetes data is in the cloud. And I think some of this idea came from those of us sitting in clinic, waiting for the data to be in our hands so we could go into the patient room, knowing that data was there last night. I could have seen the data this morning. So kind of recognizing we had some work to do to get that data entered into the EHR. And probably some of you use modern tools that upload data automatically. We don't have those tools. We enter a lot of our CGM data and other in a flow sheet within Epic, and it takes time. And we were sitting and waiting. So some of the methods we used, this is also from the change concepts there, but we found and removed bottlenecks. We worked on ways to do tasks in parallel, so not waiting for one task to be completed and then moving to the next one. The next PDSA cycle was really around modifying the clinic flow. So specifically what we did, you can see the old to new there, is we switched up the order in which we were going in the room. We had been having our nurses go in and obtain data. We had been doing things that way for about, I think, 20, 30 years. And we really shook it up. And this was with Courtney's help to say, no, really the provider should be going in first, and then subsequent services can be utilized when needs are identified. And here's where the meat is. I really like the X bar S chart. So you're seeing mean visit duration for 2-week periods here on the left side. And you can see that right when we started these changes, we had a significant improvement or reduction in our visit length. And then we've been incorporating patient feedback using Press Ganey surveys, but also just getting feedback from families. We had some cool process measures. We used a dietetics intern to sit outside workrooms and literally just tally how long a patient was by themselves in the room. And so we did that, just some pre-post data, just to get a sense that, yeah, we were reducing that wait time, so that downtime between providers going to the room, which was pretty cool. And then the balancing measures really were around patient experience. Do patients still feel like they're getting what they need? And some of that, isn't just in watching glycemic outcomes, making sure that we're not eliminating essential parts of the visit or education. Some more work to be done there. And here's a picture of my team. Here's my clinic nurse manager on the left there, Courtney. Huge shout out to her because getting people to change their behaviors in clinic is really hard to do. And I couldn't have done it without her. And here's my team on the right. All right, now I'll take any questions. Yeah, go ahead. Sheeta, I want to go first. Yeah, great question. We've iterated on that quite a bit. So now we have a care coordination assistant. So she's a non-clinical person, so not an MA. She does a lot of work for us on like prior authorization and paperwork and that kind of stuff. So she's very familiar with all the portals. So she downloads or like gets those reports, and then either her or one of the nurses will enter that data just the morning of clinic. So kind of when they arrive, they open like clinical info notes. And as long as it's the same day, we recognize that it didn't change how things were viewable in our flow sheets for during the visit. So it's a combination of our CCA and our nurses. Ideally, I feel like it's a great role, and I've heard others kind of speak on like MAs. We just don't have a lot of, we have a lot of MA gaps, and so our MAs are stretched thin. Yeah, Risa. Yeah, yeah, yeah. Great question. So the first question, and I'll repeat for those maybe listening virtually, was where did the data come from? And I feel like I asked my analyst, like, how can I measure this? Like what? And there was a reported outcome that he's been able to pull from Epic that's visit duration. There are definitely, it's not perfect, right? And so it doesn't always, like we've done some, I did some sampling to kind of assess, like, does that seem similar to what we were looking at? And it, or what we were experiencing in clinic? And the answer is yeah, most of the time. I think there are some times where the visit duration is like 600 minutes. That's happened like 2 or 3 times a year. That clearly there's something wrong with that data point. So we've decided to just remove that one. So because it's a quality improvement study, we measured it the same over time so that we did see a change. Now, exactly, is our average visit length now 63 minutes, down to 50? I don't know what our actual experience is, but we know that we've seen an improvement in a measure that we can get easily, if that answers that question. So, not perfect data. And then your other question was, oh, why? Yeah. Yeah. So then the other question was about like why the order change of nurse going in first, followed by provider versus provider going in first, change the visit duration. And I think some of it is that our nurses are not supported as or not required to be CDCESs. So our nurses have a lot of diabetes experience, though it's variable, and the specific roles and tasks for them is not clearly defined. They do provide some education, but they end up kind of going when the nurses were going in first, they were obtaining the diabetes history in their own way with patients who's not their primary patients. They don't necessarily know the patients. They're kind of getting to know the patient, obtaining history, maybe providing some education, but really we're kind of functioning more as like data gatherers. Though I think the perception was that they were providing education, but I think in that role going in first, they were really data gatherers. And then the provider would go in, repeat some of the same questions because it's very hard to share out every detail of a 30-minute conversation in a sign out. And part of it is just the sign out from one person to the next was taking a long time. And I think we've all had these experiences with families where you go in, ask questions, and realize, oh, actually, I can address most of what they're talking about. There's not really a lot of additional need. And then they can go if they're done, right? So now we've kind of shifted to say the provider can go in, assess needs, take the history. You're the one who knows the family best, and then identify if there are targeted education needs. So I think some of it is reduced redundancy. And then I think the other is actually allowing the nurses, opening up the nurses to be in a position where they can provide targeted education. I'm sorry I couldn't get to more questions. I think we're out of time, but we can chat after. Thanks.